Hello everyone. In this voiceover we are going to discuss circulatory, or it's also called distributive shock. This includes neurogenic, septic, and anaphylactic shock. This pictorial is good because it shows us exactly what happens in these types of shock. So there's a precipitating event. It may be a brain or spinal cord injury. It may be an infection or an allergic reaction. Then there's massive vasodilation, both arterial and venous, and the blood begins to pool in the peripheral blood vessels. Then to complicate things, the body enacts the inflammatory response. There's decreased venous return, which in turn causes decreased cardiac output. As a result of the decreased cardiac output, you now have a relative hypovolemic situation because you don't have enough blood volume to circulate through the body. It's all pooled out in the periphery. And the end result being, again, decreased tissue perfusion. Neurogenic shock can occur when there's insult or injury to the spinal cord and brain. Generally, when this happens, there's a loss of balance between the parasympathetic and the sympathetic stimulation. This causes massive vasodilation and decreased vascular resistance. So we have the blood pooling in the periphery because the vessels are dilated and not returning to the heart. This in turn causes that relative hypovolemic state. The thing that's different about neurogenic shock than the other shocks is that often the client is bradycardic instead of tachycardic, this being a result of the sympathetic response. Neurogenic shock, as I said, can be caused by trauma to the spinal cord, complications of spinal anesthesia, insulin shock, and overuse or abuse of some narcotics and benzodiazepines. You will talk more about neurogenic shock at the end of the semester when you study spinal cord, but we'll just go through a few nursing interventions in the next slide. Ineffective tissue perfusion related to decreased peripheral resistance is a good nursing diagnosis that supports the problem of neurogenic shock. Evidence of a low blood pressure and bradycardia also fit well with this nursing diagnosis. As far as nursing intervention, positioning is important. Certainly if there was an injury to the spinal cord, you would immobilize the client. I think that's pretty common first aid knowledge that we all know. You want to elevate the feet in order to promote venous return and to decrease the risk of thrombus formation. If a client is receiving spinal or epidural anesthesia, the head of the bed must be up as well 30 degrees, putting the client into a modified Trendelenburg, and this prevents the spread of anesthetic up the spinal cord. Certainly, due to the risk of thrombus formation or a DVT, we would want to use anti-embolism stockings. You would monitor the Hohmann sign. You would assist the client with passive range of motion for venous return, and you may be administering heparin or Lovenox as a preventative measure. Here is a good example of where you would also administer a vasopressor agent such as norepinephrine to cause vasoconstriction, to return the blood to the heart. Next is septic shock. This is the most common type of circulatory shock and the most common cause of death in the non-coronary ICU. Yet it's preventable by good aseptic technique. So there's kind of a timeline here of what happens. It starts when a client develops an infection. So maybe, for example, we have an elderly client in the nursing home who develops a UTI. If the infection goes unnoticed, untreated, or just isn't responsive to treatment, the infection, the microorganism invades the bloodstream, and then we say that the client is septic. You've heard that terminology. The immune system at that point provokes an inflammatory response, which then enacts coagulation. And that inflammatory response and coagulation lead us to poor tissue perfusion, septic shock, vasodilation. If septic shock is not reversed and progresses, very often we can see MODS, that multiple organ dysfunction syndrome that we spoke of earlier. This is a place, septic shock is a place where you commonly, more so than other types of shocks, see MODS. So when you think about the client in MODS, again, remember to think about a progression of ineffective tissue perfusion. Think about the things that you would see. You would see a blood pressure that does not respond to fluid resuscitation. You would see cool, pale mottled skin. You would see possibly urine production decrease or cease, and a progressive acidosis. Sometimes the body can enact that or provoke that inflammatory response that enacts coagulation and gets the ball rolling, and the patient begins on the journey or the continuum to develop septic shock. So it looks like this. The client may have 2 or more of the following criteria, which you can certainly read. If they do, the client can be classified as having systemic inflammatory response syndrome, or SIRS. It can then travel on the continuum to a state of septic shock, and can ultimately result in MODS and death. So this is a septic shock situation that can occur without an actual infection. Some of the acute care facilities I've noticed over the last several years are asking nurses to chart about this criteria each shift. And this is in an attempt, I believe, to help nurses to recognize earlier the signs of shock. Here is a nursing diagnosis that applies to septic shock. So again, we'll use ineffective tissue perfusion, but this time related to a compensatory response to microorganisms, or that inflammatory response. Some evidence that we might see would be an elevated white count, an elevated temp, or certainly decreased urine output, which takes us back to ineffective tissue perfusion. Here we have some nursing interventions for septic shock. First and foremost, fluid resuscitation is very important. So clients in septic shock can require as much as 6 to 10 liters of isotonic crystalloids and 2 to 4 liters of colloids. This is a good time. You certainly would monitor hemodynamics, which you would do with all types of shock, and this is a good time to review that. Remember that the central venous pressure you'd like to see between 8 and 12, higher than what you normally learned it to be, but again, in order to show that the body is stressed, by this extra fluid that it has on board, and that's what validates for you that the client has been adequately resuscitated with fluids. The mean arterial pressure, again, looks at our cardiac output and our peripheral resistance and gives us a good measure of that, and it must be greater than 65 millimeters of mercury. Remember that the pulse pressure, the distance between systolic and diastolic numbers, should be 30 to 40 millimeters of mercury. Just a refresher that cardiac output, normal cardiac output should be 5 liters per minute. That's what the heart should be pumping. And the central venous oximetry should be greater than 70%. When you have sepsis and septic shock, you want to eliminate the source of infection. So you want to culture everything. You're going to be drawing blood cultures. You are probably going to remove and replace invasive catheters. They also make antibiotic-coated central lines now that can be inserted. You want to eliminate the cause of the infection, and especially if you don't know the source of the infection, it's important to look at all your lines and anything entering the body. Foley is included in that as well. It's a direct route for microorganisms into the body. Comfort-wise, you want to bring the temp down. You may need things, if it's very high, you may need things like a hypothermia blanket. Of course, acetaminophen or Tylenol also works towards that. You're going to, we'll talk again in a minute about labs, but you're going to want to monitor kidney function, especially to make sure that the antibiotics can clear the kidneys, because if you don't have great kidney function due to the shock, you don't want to be administering an antibiotic that has to clear the kidney. White count, platelets, and coag studies that takes you back to that coagulation response that occurs in septic shock, and certainly you'll want to monitor blood count. Nutrition we'll also talk a little bit more about in a minute, but malnutrition is known to further exacerbate a client's resistance to infection. So I think earlier I've talked about the importance of nutrition, being in nutrition supplements being administered as soon as the client in shock is stable. We're looking at about 3,000 calorie supplements to be started within the first 24 hours of care. We tend to go with enteral feedings over nutritional supports through IVs and central lines so that we decrease the risk of infection. Here's some more lab tests to think about. Certainly ABGs are important for any client in shock to see, kind of gauge where you are between an alkalotic and an acidotic state. Cardiac enzymes and a BNP, again for any type of shock where we have hypovolemia, which can lead us to cardiogenic shock, or certainly an injury to the heart such as an MI. We want to get at these will give us an idea about cardiac output and cardiac function and stress on the heart. Basic metabolic panel can take us, again, these are for any type of shock, these labs. Basic metabolic panel can take us through looking at all of those things we would see with decreased tissue perfusion, like kidney function. We can also, we talked in the very beginning about hyperglycemia, we can also measure the blood sugar with a BMP and the state of our electrolytes. You've got that permeability and sodium and potassium moving around. So you could take a look at those levels. Also platelets, fibrinogen levels, clotting factors. And the reason that you want to look at these labs is because you have that coagulation response enacted and want to be sure that the client doesn't develop DIC. And here is the role of nutrition, which again is important. Remember, I said that malnutrition can exacerbate a client's resistance to infection. So important to start in the first 24 hours. If it is parenteral, we want to possibly administer continuous infusions of insulin based on that hyperglycemic state which can be occurring. So you would also be monitoring the blood glucose level, but the preferred route is enteral, less chance of infection, begins to help the GI tract become perfused, because remember there was decreased perfusion to the GI tract as blood is shunted away to more important organs. So nursing care here involves bowel sounds, weight. Certainly you're not going to feed anybody with enteral feedings unless they have bowel sounds. Weights, INOs, and ongoing assessment of lab values that indicate good nutrition. Last type of circulatory shock, anaphylactic shock. So this is a severe allergic reaction that occurs when a client is exposed to an antigen that they have already developed antibodies for. So there's a rapid onset. Client is usually immediately hypotensive, maybe in respiratory distress, and it can, untreated, result in cardiac arrest. So what happens is the antigen-antibody reaction provokes mast cells to release potent vasoactive substances like histamines. This causes, the histamines cause widespread vasodilation and capillary permeability. Hence, this is how we get into that circulatory shock state. So again, we've got blood pooling in the periphery. Nursing diagnosis, ineffective tissue perfusion related to antigen-antibody response. Evidence might be shortness of breath and anxiety. Certainly anxiety, because if you can't breathe, you're anxious. Also, impaired gas exchange applies here, related to bronchospasms, which is an effect of the anaphylactic shock, and evidence here may in fact be wheezing. So how do we treat anaphylaxis? Well, first and foremost, prevention is the key. So sometimes they seem like insignificant interventions like IDing client allergies are really important, really key. The most common cause of anaphylactic shock is penicillin and contrast dyes. So I can't stress enough the importance of identifying your client allergies. A medic alert bracelet also speaks to prevention. And certainly your careful monitoring of a client's response to any new medication. So here we're going to look at administering vasopressors or vasoconstrictors such as epinephrine. We may certainly want to give an antihistamine such as Benadryl to counteract that histamine, the release of the histamines in the body. Corticosteroids such as albuterol or salumedrol can certainly help open up the bronchi, and aminophylline for really severe bronchospasms and wheezing.